Good afternoon, friends. I'd like to congratulate Dr. Rakesh Garg and Guidelines Committee member for All India Difficult Airway Association. They brought All India Difficult Airway Association 2025 guidelines for the management of unanticipated difficult airway in obstetrics. This was published in Indian Journal of Anesthesia, November 2025. The guidelines has a very real downstream consequences for intensivists. That is why each intensivist must understand the intricacies of these guidelines and what are the applications and implications for critical care practice from these guidelines. Especially those who are running mixed ICUs, medical surgical ICUs, obstetric ICUs, or emergency airway teams on behalf of critical care teams must understand obstetric airway difficulties. It is one of the most difficult and a nightmare often for most of us who have been dealing with obstetric emergencies. What we are going to discuss is ICU-centric interpretation of this very important guidelines. And we have no other than Dr. Rakesh Garg. Dr. Rakesh Garg is professor, AIMS Delhi, and he has been an avid researcher, a good clinician, a very dear friend to most of us. Why these guidelines matter to us intensivists? Obstetric airways that go wrong don't end in the OT. More often they land in the ICU. We understand complications like hypoxia, aspiration, pulmonary edema, failed intubation, difficult extubation, failed extubation, emergency tracheostomies, or worse come the neurological injury. These guidelines recommend a redefined expectation from ICU teams for obstetric airways. My first question to Dr. Rakesh Garg, I'd like you to explain what are the key points in this airway guideline for obstetrics.
Thank you, Dr. Javeri, for taking this initiative. I fully agree with you that as a critical care team, management of a parturient, a pregnant patient is a team approach, which include anesthesiologists, the obstetrician, and definitely with the emergence of obstetric critical care unit, it becomes important that all the members should be at the same platform. And that was the reason of All India Difficult Airway Association to bring its updated guidelines of management of airway in patients who are pregnant, parturients, and how to manage it. If you see the key features, we understand that pregnant parturients have some physiological change. And if we understand those physiological change, they are considered like full stomach. They have some edema of the upper airway because of the hormonal changes. They have bodily changes with regards to the hemodynamics. So, considering those physiological changes related to pregnancy, what key points the AIDA emphasizes about the airway management? One is that we need to understand that each obstetric patient is potentially difficult, primarily because of the physiological change. When we say difficult airway, AIDA has also proposed something called Code D, which is equivalent to call for help in case of an emergency airway, difficult airway. So this is important because here we are treating two lives. Any episode of hypoxemia can lead to hypoxic damage, and hence activation of code D becomes important. Three, when we say the airway of pregnant patient, because of hormonal changes, they are more edematous. And if we try to have multiple fiddling with those airways, they can be a cascade of edema, and that can lead to airway obstruction. And this emphasizes that we should not be fiddling with the airway too much. And that's why, in case we have a failure of the airway management in first attempt, we can have maximum 2 attempts, because more attempts, more edema, more airway morbidity can lead to complications. But yes, since we have many experts into the team, since we have already activated code D, expert help come, we can always allow one extra attempt by the expert who is expert in managing these patients. But remember, we are talking two lives. I mentioned about hypoxia. At any point of time, if the saturation is less than 95%, multiple attempts should be avoided. There has been a lot of literature with the regards of using different type of airway management tools, and it has been emphasized in multiple research, and AIDA also supports those researches with regards to the use of video laryngoscope as the first airway device. We also have research where supraglottic airway device has been used. They can also be used as a rescue measure in these patients because they have a risk of some regurgitation, aspiration, and all those things. But remember, it is the second generation device that needs to be used because they can sustain higher airway pressures, higher leak pressures, and hence next less chances of the risk of aspiration in these patients. The oxygenation remains a priority. During the airway management, we were talking about pre-oxygenation, oxygenation, but remember, during the airway management, these patients should receive highest FI and highest flow. If you have the HFNC, 100%, 30, 40, 50, 60 liters. If some constraints, at least use the highest flow. If you have in OT, not HFNC, at least two installed oxygen should be used as maximum as possible. And if you are not struggling with the airway, your attempts fail. If you see the AIDA guidelines, there are more circular guidelines wherein you can try choosing endotracheal tube to the face mask to the supraglottic air device with the primary aim to maintain saturation. But at any point you think that you are not able to attain an airway with using these devices, here comes the role of surgical airway. And we label it as complete ventilation failure. This term is little different from the cannot intubate, cannot oxygenate, or cannot ventilate situations, because at the complete ventilation failure, when we are using high FI and high flow oxygen, there will be increased duration of apnea, but it is not infinite. Hence, even in the complete ventilation failure, we know that at some point the apnea duration, though extended by 5, 10, 15 minutes, some studies even 30 minutes, but then the hypercarbia will start happening. So this is an indication we will say that the emergency surgical cricothyrotomy should be the choice here. And in case if you are able to secure the tube, ensure that it is a difficult airway, ensure that you are able to identify the correct position of the endotracheal tube using the visual method, using the auscultation method, but definitely by having a waveform capnography. And it should have the consecutive sine waveform capnography, which confirms the correct placement. And having said that, Dr. Javeri, you also mentioned in the beginning, and you are well aware and proponent of the good communication, good teaching training, good teamwork, and practicing on a simulated scene prior so that the whole team is sync with the safest airway management in these patients.
Very nicely put up and very, very simplified. Thank you, Dr. Garg. I'll still try to bring up the salient points for the sake of our audience. Preparation over prediction, early call for help, code D, limited intubation attempts, video laryngoscopy would be preferred in a difficult situation, early use of supraglottic airway devices, oxygenation always takes priority over intubation, and do not make an already difficult airway more difficult by secondary injury or multiple attempts without changing anything. Wake up strategy is acceptable in some situations. Clear progression to FONA is mentioned and cricothyrotomy should be resorted to when need arises. Cricothyrotomy is the preferred emergency FONA. Post-airway care is also critical, especially in the post-op ICU or a critical care unit. Structured communication and handover and simulation training is also mandatory. So, understand all these important points. This brings us to the second important point. Dr. Rakesh Garg, I'd like you to focus on this. Higher threshold for repeated intubation attempts. What does this mean for an average clinician?
So, as we were discussing earlier, when we talk about the intubation, now in this subset of population, when we talk of obstetrics, and this is applicable to the pediatric patients also, to a certain extent, this is also applicable to septic patients into the ICUs. When we try to have multiple attempts, there are risk of the edema, the risk of bleeding. And in those situations, we have to limit an attempt so that we are not further compromising the anatomy of the airway. They're already having some physiological changes. If we add an anatomical difficulty in addition to the already existing difficulties, the patient can land up into a complete ventilation failure from both the aspects. And that's why we say limited intubation attempts. Second point, which is quite logical to understand, that if I am failed with an attempt, what will I gain if I repeat the same attempt in a similar way? So there has to be something different. Maybe our technique is different. We have already optimized the patient position. The intubator is different. So second attempt should have something different so that our success rate increases. So we should not be repeating the same person, same technique, same maneuver and trying to just get lucky to get it. So AIDA strongly discourages this aspect. And then we can look for the subsequent step, what needs to be done. Now, since if we are failed into intubation, we have something as a rescue, the second generation device. Now, when we insert a second generation device in these patients, yes, we are able to ventilate in certain situations. But sometimes, even those supraglottic airway devices may have some difficulty. If you try to ventilate, they may have leak. But then we are able to supplement some oxygen through these devices. Now, what option do we have is we can intubate through the supraglottic area devices. If we talk about second generation devices, majority of them allows a 6.5 millimeter internal diameter cuff tube to be passed through the supraglottic airway devices. And then we are able to secure the airway and can continue the case or the post-operative management in the critical care unit for these patients. Simultaneously, one thing that needs to be remembered is now most of the guidelines worldwide, including the AIDA core committee, discourages blind intubation through supraglottic airway devices because blind intubation can lead to more damage. We are not very sure about it. So it should be guided one. And we already have, everybody has video scopes with us. We can use those video scopes and then take it towards the safe intubation through supraglottic airway devices. Now, third, at times those surgeries may be elective surgeries, planned surgeries. And if we think we are struggling, the patient can be awakened up rather than having multiple failed attempts and leading to more morbidity and maybe sometimes complications. We can wake up the patient, we can have help, we can reassess the patient and can replan the patients for airway management. So this is what we also mentioned about the wake up strategies in case mother and the fetus is reassured for any emergency delivery of these babies. So these are the options where we probably say that the repeated intubation attempts should not be done to an extent where we are causing more iatrogenic injuries to these at-risk patients. And this is what is more important for obstetric. And we can, if we talk about pediatrics and the critical care septic patients in some other sessions, again, the same broad principle, though physiology is different, but broad principles remains the same.
Thank you, Dr. Garg. This brings us to a very important point, care of the patient post-surgery, post-intubation. So once the ICU takes over, especially in difficult airway situation, controlled ventilation, difficult and timely extubation, you have to be going for a protocolized extubation, go for the leak test, look at other risk factors, prepare post-extubation NIV requirement, re-intubation or a FONA sort of situation post-extubation. Airway edema management remains a concern even after intubation, the patient is in post-op care or ICU care. Intensivists must plan delayed extubation protocols in obstetrics and have a protocolized approach. Do not just extubate a difficult airway without preparations. Aspiration risk is also explicitly explained in these guidelines, and we understand despite modern fasting protocols and neuraxial preference, GA in obstetrics still carries a significant risk of aspiration because of full stomach physiology, various reasons we are all aware of. Failed RSI again adds to the risk. The consequences for intensivists are many: pneumonitis, ARDS like picture post aspiration, need for long term ventilation, and PEEP titration. So, ICU teams should be actively looking for consequences of aspiration. It might have been micro aspiration. Aspiration could have gone unnoticed because the airway was priority at that particular moment. So beware of these complications. Next, we go on to the most important intervention in medicine, which is communication. Communication failures adds to morbidity and mortality in operative room, in wards, in ICU. How important is communication as a tool for difficult airway in obstetrics, Dr. Garg?
Absolutely. I think you have actually touched the most important aspect. Skill is one, but when we talk about skill, the soft skills also becomes very important. And this is what, when we manage these patients, it's a teamwork. And in teamwork, the important aspect is yes, preparation, but should be some clear communication of starting a difficult case, number one. Number two, in case we are stuck up, we have to call for help. And that's why AIDA has taken this initiative for the first time to declare something called Code D. D here stands for difficult airway. Now, when we say emergency in an obstetric patient, it could be many. It can be hemorrhage, it can be fetal distress, it can be airway, it can be any other organ dysfunction like eclampsia and other aspects. And hence, we should be focusing on the difficult airway in case if this is the situation. And that's why I say activation of code D, which is very clear indication that this patient, apart from other things, right now requires an expert who can manage the code D. So this will take care of the communication error that what type of help is required. Second, when we talk about declaration of the failed airway and announcement of code D, we need to have difficult airway cart ready, and the team should be able to understand what we want. Now, the whole process of the communication, we are using multiple equipments: endotracheal tube, supraglottic airway device, the face mask. In addition, we are looking for the difficult airway and failure. So we require emergency surgical cricothyrotomy kit. In case supraglottic airway devices, we need fiber optic and a smaller size tube of 6 and 6.5. So this communication will also emerge when we start having something simulated programs where each person has a dedicated role. Not only communication, but the assignment of a role to the correct person at the correct time also becomes important. And then we need to understand the requirement. Say, for example, when we talk about the obstetric patient, we did talk about the cricoid pressures. Now, person should know the correct method of cricoid pressure, but in case if cricoid pressure is leading to further difficulty, he should be able to remove it, and other person should be very well ready with the suction in case if the patient regurgitates. So this shared mental model or this understanding of the individual role becomes very important. Now, once we have managed the airway, you rightly touched upon the extubation part also. So again, these patients needs to be handed over to the critical care team. And what has happened intraoperatively or into the operating room has to be communicated in a clear language, the technique they have done, and probable complication that would need to be assessed further very clearly needs to be communicated to the critical care team so that before they proceed further, they know that this was the problem, this thing has been done, and this is the potential problem that can happen, and we need to look for.
Very clearly explained. So our handover should be very, very structured and airway handover should be proper. And we need to have a document, number of attempts, grade, devices, complications there, complications to expect. Team communication and shared mental model Dr. Garg touched upon. How to go for awake extubation and airway edema issues, Dr. Garg?
Right. So once we have given a care, so now once the patient has an airway, definite airway in situ, the extubation is not emergency. It's a purely an elective procedure. So earlier we have struggled with intubation in this patient. Unfortunately, we have managed it. But now extubation remains an elective procedure. We have time, we can optimize it. Now, the edema can happen. Maybe the physiological edema, or it may have an exacerbated because of our attempts. So we need to look for the airway edema. And that's why AIDA has come with the 3-limbed approach for extubation. Now, if we suspect edema in these patients, what we can do is we can look for certain signs of airway edema. People were using early qualitative, like putting the stethoscope on the neck area, deflating and looking for the thing, but they are very subjective and they will not give you clear-cut way. So AIDA strongly recommends using quantitative method of the leak test. So we have clearly defined how to do it. So when the patient is still on ventilator, we need to see the change in the expired and inspired tidal volume with the cuff inflated and deflated. More than 110 ml, more than 25% change the difference indicates if there is more, this means leak is there. If leak is there, this means edema is not there. We can safely extubate. If there is no leak, this means that in spite of the deflating the cuff, the mucosa is impinging on the trachea. This means it's edematous. And hence, we should be cautious in removing the tubes in this patient. We can wait for some time, keep the patient head up. Sometimes we can use the nebulization of the adrenaline. Maybe a single shot of steroid, if not contraindicated, would lead to the decrease in the edema on the periglottic structures. So these are the measures that majority of time will subside over hours, maybe 6 hours, 12 hours, 24 hours. We can repeat the test and take the decision accordingly. But remember, uh, if there is any doubt, we need to extubate these patients once they are fully awake. We can do a guided extubation. Either we can look for those issues while extubation by putting a fiber optic scope. And while we are removing the tube, we can see that edema is there. If yes, we can reintubate the tube, or we can use airway exchange catheters and keep it for some few minutes to few hours till the patient is able to maintain the airway. If everything is fine, we can remove the airway exchange catheter. If by chance something is happening, we can reinsert the endotracheal tube over it and then look for what next to be done, depending upon the severity of edema, the reason of edema. But majority of time, it should subside in a couple of hours, maximum for 24 hours.
Thank you, Dr. Garg. So we must understand extubation, especially in difficult airway situation, is a tricky thing and it has its art and science. So we must have a protocolized approach not only to weaning but also for extubation, especially in a difficult airway situation. Leak test, consideration for steroids in specific cases, readiness for intubation or surgical airway is must while we extubate such patients. Next and most important aspect which we'll be touching now is simulation and shared training expectations. AIDA is pushing for regular simulation and algorithm familiarity. Beyond this goes beyond OR because such airway can come in emergency, it could be in ward, it could be in ICU. So Dr. Rakesh Garg, how well we should be simulating and how well should we be prepared to deal with such cases?
I think you have touched a very sensitive point and important point, in fact. And as critical care physician, the whole team of the critical care physicians in India and abroad are very, very familiar with simulated conduct of various emergencies, and this remains one of them. When we say the simulation, we should understand the for this particular patient who should be the team members. So we need to have a obstetrician with us. We also need a neonatologist. If it is sometime we need a perimortem for I am an unfortunate situation needs to struggle with them, needs to monitor with them. We need to have a technical person, or you can say who arranges all the airway equipments and help us. We need to have a critical care physician who understands very well with the change in the physiology, and they are the best person to understand and optimize them, because now once we extubate them, we have to stabilize those physiology. So critical care physician should understand the interaction of various organ systems. Sometimes these patients, if they have some minor cardiac morbidity, they can go into failures, they can have hemorrhage, they can bleed. So those also needs to be taken care of. Now, when these people come together, there are certain basic things that each member should know. One is the stepwise approach. Second is when to intervene by whom. For example, if it is a situation wherein the patient is going to bleed, then the obstetrician should know what to do next. Is a conservative pharmacological management, or it will require surgical intervention by shifting the patient to the OR. So these teamwork, the assignment of role to each other, understanding of the basic aspect, and clear communication between members when to take which step should be clear. And that's why if you see the algorithm, I think it will be a good thing if you just take a small printout and paste it in the area where these type of cases are usually managed, so everybody will be in the same platform. We want the safety of not only mother but the baby also. So by this simulation practices of including people around, the multidisciplinary approach, the technical support, the critical care nurses, I'm sure that we will be able to bring out a safe outcome of mother and the baby.
Thank you, Dr. Rakesh, for enlightening us about various aspects of difficult airway in obstetrics and the implications for intensivists, which goes beyond obstetrics. These are common sense and scientific approaches, which obviously goes beyond the walls of OR or ICU and beyond the paradigm of obstetrics. So I'd like you to give us the final message to the audience and the bottom line for the intensivist.
Thank you so much for giving me chance to interact with the august audiences who are listening to us, Dr. Javeri. Uh, this remains an important aspect. The government, various policymakers across India and across world are looking for decreasing the maternal mortality rate. And this remains one of the issues where at least we as trained physicians, trained critical care experts, anesthesiologists, obstetrician can put our role to bring a safe maternal perioperative care to these patients. And just simple things, understanding the physiology, keeping abreast with the soft and the skill based learning in these, applying those skills in a stepwise approach, and being well versed with the each step, when to use which equipment, a little training on a surgical airway by each one of us, because it's a simple procedure of surgical cricoidotomy, which just require one endotracheal tube, a bougie, and a stab blade, nothing else. These three things should be there at all places who are managing these patients. Learning them on animal models, goat models, and mannequins will just require 5 to 10 procedures. We will be able to manage these patients, but these are life saving. And conducting sometimes simulation programs will make us not only comfortable, but I will say a little more confident to avoid those panic situation when the code D happens in patients, the parturients who require airway management for whatever reasons. So I'm sure that if you follow this, we can provide a safe motherhood, and we can also provide a healthy, neurological intact, a baby which is yet to be born by providing this care.
Thank you, Dr. Garg, and thanks to AIDA for bringing up this important guidelines. And thanks, audience. Happy learning. See you soon again. Bye bye. Thank you.